Here is something that has always stayed with me from years of clinical practice. The people having heart attacks are almost never the ones making noise in the waiting room. The person having a heart attack is typically the one sitting very still in the corner, pale, clammy, holding their chest quietly, speaking softly if they speak at all, not shouting, not crying out, just sitting there looking profoundly unwell. The loudest, most dramatic pain is rarely cardiac. The most dangerous heart attacks are often disturbingly quiet. And that disconnect between what people expect a heart attack to feel like and what it actually feels like is why people delay getting help, why they rationalize symptoms, why they wait, and that delay costs heart muscle. In some cases, it costs lives. Today, I am going to walk you through 6 warning signs that people consistently miss or ignore, not because they are careless or in denial, but because they genuinely do not recognize these symptoms as dangerous, and there is no reason they would, unless someone told them. My name is Dr. Victor Hayes. Understanding these 6 signs could be the most important thing you do today. Let us go through them. Before we get into the specific signs, we need to dismantle the biggest myth about heart attacks, the idea that they cause the most severe pain imaginable. Cardiac pain is fundamentally different from most pain people are familiar with. Muscle pain is sharp and localized. Nerve pain is shooting or burning. Injury pain is immediate and intense. Heart attack pain is typically none of those things. What heart attacks produce is pressure, squeezing, tightness, a sensation of weight. Patients describe it as something sitting on them, as a tight band around the chest, as their ribcage being slowly compressed. It is deeply uncomfortable and feels profoundly wrong, but it is often not agonizing in the way that a broken bone or a kidney stone is. That gap between expectation and reality is precisely what causes people to second-guess themselves. In emergency medicine, noise does not equal danger. Silence often does. The person screaming needs assessment and treatment, absolutely. But the person sitting utterly still, pale, quietly sweating, terrified, that is who I worry about most. Warning sign number 1 is chest pressure, heaviness, or tightness, but not the sharp stabbing pain that most people expect. What heart attacks actually produce is a sensation of heaviness, squeezing, or constriction sitting in the center of the chest that does not move. Patients describe it as a heavy weight pressing down, their chest in a vice, or something wrapped tightly around their ribcage. Some describe an elephant sitting on their chest, which sounds dramatic, but captures the nature of the sensation more accurately than most descriptions. The critical clinical distinction: if the pain changes when you move, when you breathe in deeply, or when you press on a specific area, it is less likely to be cardiac. Musculoskeletal pain shifts with movement and position. Cardiac pressure does not. It sits there, constant, central, unrelenting. That persistence is what should trigger alarm. If you are experiencing that kind of pressure and it is not resolved after a few minutes, that is not something to wait out at home. Warning sign number 2 is pain that spreads beyond the chest. Cardiac pain does not always stay in the chest. It radiates. And the pattern of that radiation is one of the most important features we look for clinically. The reason this happens is that the heart and the left arm share nerve pathways that converge in the spinal cord. When the heart is in distress, the brain can misinterpret where the signal is originating. This is called referred pain. The nerves from the heart feed into the same segments of the spinal cord as nerves from the arm, neck, jaw, and upper back. In practice, this means heart attack pain frequently spreads to the left arm, which is the most recognized pattern, but it can also radiate to both arms, the neck, the jaw, the shoulder, or the upper back. Jaw pain in particular is regularly misidentified as dental pain. Some people go to a dentist when they should be going to an emergency department. If you develop pressure in your chest that radiates into your arm, neck, jaw, or back, that combination requires urgent assessment. Warning sign number 3 is upper abdominal pain, and this is one of the most consistently missed warning signs I encounter. Heart attacks can genuinely present as pain felt at the top of the abdomen, just below the rib cage. This gets attributed to indigestion or heartburn constantly, because that is exactly what it can feel like. And because people associate heart attacks exclusively with chest symptoms, they assume what they are feeling must be digestive. The anatomy explains why this happens. The heart sits close to the diaphragm, and there are shared nerve supplies with the upper stomach. Cardiac pain can genuinely be perceived as abdominal pain. People take antacids, wait, and delay seeking help, sometimes for hours. This presentation is particularly common in older adults, in people with diabetes, and in women. In these groups, the classic chest pain pattern is less reliable and frequently absent. Upper abdominal discomfort may be the dominant or the only symptom. If you have upper abdominal pain that is new, persistent, and not settling the way indigestion normally would, especially if it is accompanied by sweating, nausea, or a general sense of feeling unwell, consider your heart, not just your stomach. Warning sign number 4 is sweating, nausea, or a sudden profound sense of feeling very unwell, without an obvious cause. When a heart attack occurs, it does not just affect the heart muscle. It activates the autonomic nervous system, the part that controls unconscious functions like sweating, heart rate, and digestion. This activation produces what we call autonomic symptoms: cold sweats, nausea, dizziness, feeling faint, and a general sense that something is very wrong. Patients describe a feeling of impending doom, which sounds vague, but is a recognized clinical symptom. The skin becomes clammy, pale, or gray. The person looks unwell in a way that is hard to quantify, but immediately recognizable to anyone who has spent time in emergency medicine. When someone looks profoundly unwell without a clear reason, no obvious infection, no injury, no clear cause for the pallor and sweating, the heart moves very high on the differential diagnosis, particularly in anyone over 55. These symptoms alone might not indicate much, but appearing suddenly, together in someone with risk factors, they represent a red flag that demands urgent evaluation. Warning sign number 5 is shortness of breath, particularly when it is unexplained or disproportionate to any physical effort. Some heart attacks cause relatively little chest pain but significant breathlessness. When the heart muscle is damaged, it cannot pump blood effectively around the body. Oxygen delivery to tissues falls. The lungs work harder to compensate, and the result is breathlessness that appears without a clear respiratory explanation. This pattern is especially common in elderly patients, people with diabetes, and those with previous heart disease. The chest pain may be mild or entirely absent, but the breathlessness is pronounced and often frightening. The red flag I look for clinically is sudden shortness of breath at rest without a clear respiratory trigger. No cough, no wheeze, no known asthma. Especially if it is new or different from anything the person has experienced before. If you are sitting still and suddenly find yourself unable to catch your breath, or if you become breathless doing things that have never challenged you before, that needs evaluation. Warning sign number 6 is sudden, unusual fatigue or profound weakness, and this is the most subtle and most easily dismissed of all. Cardiac fatigue is different from ordinary tiredness. It is sudden, profound, and unexplained. What is happening physiologically is that reduced blood flow from a damaged heart means reduced oxygen delivery to muscles and tissues. The body feels exhausted because it literally lacks the fuel to function normally. Patients describe feeling completely drained, unable to perform routine tasks, sensing that something is fundamentally wrong with their energy without knowing why. The phrases I hear repeatedly are things like, "I just felt wrong," "I had no energy at all," "I could not even walk to the kitchen." A sudden, unexplained exhaustion, one that is new, that comes on without an obvious trigger like illness or overexertion, is not something to normalize or push through without investigation. I also want to address one more important concept: silent heart attacks. Some heart attacks cause very mild symptoms, vague discomfort, or no chest pain whatsoever. These are called silent or atypical presentations, and they are more common than most people realize. They occur more frequently in people with diabetes, because chronic high blood sugar damages nerves over time, blunting pain perception. They occur more often in older adults, whose nervous systems are naturally less sensitive. And in women, heart attacks more commonly present with fatigue, nausea, and breathlessness rather than classic chest pressure. Silent does not mean harmless. The heart muscle is still being damaged. The consequences are equally serious. The difference is that the warning signals are muted, making them easier to miss and treatment more likely to be delayed. Now, the important context I want to provide. Having any of these symptoms does not mean you are automatically having a heart attack. The vast majority of people with upper abdominal pain or arm discomfort or fatigue are not having cardiac events. Indigestion is far more common than heart attacks. Muscle strain is extremely common. Fatigue has countless causes. What matters is your individual risk profile. If you are older, if you have high blood pressure, diabetes, high cholesterol, a sedentary lifestyle, or a family history of heart disease, and you develop any of these symptoms, the threshold for seeking assessment should be lower. The probability that those symptoms represent something serious is higher in your case. If you are a healthy 30-year-old with no risk factors, an isolated episode of abdominal discomfort is almost certainly digestive. But if it is accompanied by other symptoms, sweating, nausea, radiation to the arm, shortness of breath, do not rationalize it away. Here is the principle I live by clinically. You do not need to be certain it is a heart attack to seek help. You just need to recognize that it could be. The embarrassment of a false alarm in an emergency department is infinitely preferable to the consequences of delayed treatment. Time is heart muscle, and heart muscle does not regenerate once it is lost. If you have any doubt at all, seek medical assessment. Your heart cannot afford to wait. Please share this video with the people in your life who need to hear it, and subscribe to this channel for more evidence-based content that could genuinely make a difference. I will see you in the next video.